Our speaker today, Dr. Fanucchi, is a board-certified physician in internal medicine and addiction medicine. She provides treatment for opioid use disorder in the UK Bluegrass Care Clinic and the UK First Bridge Clinic. Dr. Fanucchi's research focus is in integrating evidence-based treatment of opioid use disorder in medically complex patient populations. She has presented regionally and nationally on the management of hospitalized patients with opioid use disorder and provides trainings to physicians and other members of the healthcare team. Dr. Fanucchi is also a co-investigator on the treatment team of the Healing Community Study. So everyone, please welcome back Dr. Laura Fanucchi.
Thanks, John. Hope you all are doing well. I'm going to share my screen. So we reviewed this last week, but as a reminder, we are talking about the role and evidence of various behavioral interventions in the treatment of patients with opioid use and medications for opioid use disorder. We talked about how to incorporate behavioral interventions into a treatment plan with medications for opioid use disorder. We talked about explaining the efficacy of different behavioral interventions in the treatment of opioid use disorder. And we went through the basics of contingency management, cognitive behavioral therapy, and community reinforcement approach, and a couple of others in the treatment of opioid use disorder. So hopefully at the end of these two sessions, you'll have an enhanced understanding of the role of behavioral interventions when treating persons with opioid use disorder. So just a review of some of the main concepts from last week. Remembering why we emphasize medication in treatment of opioid use disorder. Ultimately, the medications save lives, and counseling alone or treatments that don't include medication, unfortunately, are ineffective and increase the risk of overdose death. The other thing that's critical is that medication management does include basic counseling. So it's not that the person just goes in and receives a script and walks out with no counseling type interventions. And I think that that's a common misconception. And some people with opioid use disorder certainly do benefit from additional counseling. The trouble is that we don't know who will necessarily receive additional benefit or what specific modality would be most helpful for a particular individual. Overall, the medications for opioid use disorder really reduce the risk of death in individuals that have opioid use disorder. So if we look at the population as a whole, that's the general population bar in green there. And we say that their risk of death at any given time is 1. And that's standardized across the general population. And then for people with opioid use disorder that are not in treatment, their risk of death is over 6 times that of the general population. And when starting medications, when they're on medications for opioid use disorder, specifically buprenorphine or methadone, that does not bring the risk of death back to 1, the same as the general population, but it does, you can see, decrease it dramatically to less than 2-fold the risk of the general population compared to more than 6-fold, which is a very dramatic decrease. And certainly as far as treatments that we have available in medicine for other chronic diseases, this is a very, very significant decrease in risk of death. So another quick reminder, in methadone treatment and licensed opioid treatment programs, there are involved counseling requirements that are come from federal and state regulations that people have to participate in as part of receiving methadone in an opioid treatment program. because of the regulations, there is a certain panel size of patients that an individual counselor can have. And sometimes when a person is entering treatment at an opioid treatment program, they may not have space in the counselor's panel size to take on another patient. And so sometimes those patients are placed on a waiting list to enter treatment. And what studies have demonstrated is that if you provide the medication without the counseling in the beginning while they're waiting for a spot to open up on the counselor's roster, then people are much more likely to stay in treatment with methadone. And so ultimately the message here is that counseling requirements shouldn't delay starting medication. And that there's a federal regulation that allows starting medication without counseling for up to 120 days in an opioid treatment program. So in buprenorphine treatment, which is typically in an outpatient office-based setting, a number of studies have been done looking at adding counseling to medical management in buprenorphine treatment. And consistently, multiple studies in multiple settings with many patients, different behavioral interventions essentially demonstrated that groups that had more intensive counseling had similar rates of reduced opioid use as medical management alone. So those are the studies that lead us to basically recommend that it's not one size fits all. So we can't say, if everybody entering treatment attends this type of counseling several times a week, they're more likely to stay in treatment than someone who comes and does medical management alone. In fact, it seems that it's really quite clear that the medication reduces the risk of death, and then that encouraging people to participate in other forms of behavioral interventions is definitely important, but we can't know which specific intervention is going to work for any one person. And so we shouldn't force people to be in any one structured behavioral intervention. As a reminder of the basic concepts of contingency management. So contingency management is a behavioral intervention that is based in operant conditioning. And operant conditioning is the concept of changing a voluntary behavior based on a cue, and in this context, a reinforcer or a consequence. So positive reinforcers are things that are pleasant to increase the frequency of a behavior. So can I ask the group to talk about some things that would be positive reinforcers? And we can talk generally, what are positive things that as human beings we return to that the positive experience of doing those things or having those things is reinforcing. And so it increases the number of times that we do those things.
Being with family.
Mm-hmm.
I worked in an MOU with an MOUD provider before that had kind of like a very literal process of this. So they used an app called Resetto. I'm not sure if you all have heard of it, where the patients were rewarded for different successes in the program. So appropriate drug screens, showing up for counseling, completing different education modules, and it was like a spin on a prize wheel where they could win like monetary gift cards to Amazon and different restaurants and things like that.
Yeah, that's perfect. So Resetto is a virtual contingency management platform, essentially. And we talked about it last week, but they have a number of web-based modules that are based in community reinforcement approach. And then as you said, people can, when they participate in those modules and they have appropriate urines, they can win, they can receive increasing value rewards through the app. And so that is a perfect example of contingency management. And those are, I think, unique and innovative things that have come into the treatment space more recently. The problem that we've encountered, at least in my clinical practice, is that it's not covered by insurance. And so there are some barriers to implementing it more broadly, but thank you for bringing up that example. Anyone else?
Within the Department of Corrections, if a client completes intensive outpatient or inpatient, they'll get 90 days taken off their sentence. And they really like that.
Yes, absolutely.
It's like freedom, right? So getting more freedom. Some of the other things were like kind of getting at money, right? Like sometimes it's like getting at money by help with transportation or something, or, you know, things that are saving them money in a way. Maybe if they have, what's it called? If they have like a copay, if they don't have to pay as much copay, like, and you were to reinforce that by saying that you would get a longer duration of a prescription if they have consecutive, you know, urine tests that are negative for illicit substances, that they would get like a longer prescription, which would mean less of a copay because they wouldn't have to go to the pharmacy as much. And then maybe that's also like a savings for them with gas money. So I know it can be hard to pay people in treatment currently.
When people show up to groups in one place where patients go for medication for treatment, if you're there for group, you know, 30 minutes early, then you get a ticket and go into a raffle to win prizes.
Yep, those are all really great examples. And so there's good evidence that contingency management, that this strategy is helpful for people in reducing. So there are studies done on reducing use of other substances in treatment for opioid use disorder. So if someone's on buprenorphine and they maybe also have a stimulant use disorder and are using cocaine, there are studies that look at contingency management in reducing the number of reducing the frequency of use of other drugs, and similarly to help people stay in treatment with buprenorphine or methadone.
It kind of makes just in terms of just discussing it, I think that the more that I've thought about it, like the more I can see how some of this is kind of like just normal stuff about how we learn and how we learn things, even from being like itty bitty and growing up. And I think maybe how hopefully some people have been parented with, you know, being given rewards for behaviors that we want to see of our children, right? And how we like shape behavior, right? Like how is it that we went from feeding ourselves just with our hands, right, to actually using a fork and a knife and, you know, like doing things the way that's culturally accepted. I think as we try and give rewards, and I think someone initially said like what would be reinforcing was family. And I think that was bringing to mind like that sometimes that is definitely the goal, but lots of times people's families aren't reinforcing. And so sometimes the clinic becomes, quote, the family, because they can be the only positive thing in a person's life too. And so just this idea that normal humans, we all want to feel good. And that the way we've, I think, try to shape behavior in our own culture and our own families, if we've parented at all, like it's that we use a lot of contingency management, I think, in operant conditioning. I don't know what people think about that, but that's been helpful to me as a physician working with like behavioral disorders. So
I think that, and again, my question this week kind of was on this subject. So I'd like to just share that if you prop up someone with something that's not, and I'm not sure the word intrinsic or, like family versus something you win in a raffle, the difference between the two in raffles come, go, you win, you don't win. So if you make that the system based on treatment and their recovery, and something happens with that, then where are they going to go from there? So, that's why I say start off with those things. And from my experience so far, that's what most people who are in recovery and wanting to come into recovery say is family and, those sort of things is what will help them. And on their hierarchy of values, what they value the most are those things. You don't see trinkets. I don't mean to say, but I think I've said enough.
So I think that that it's not, and I'm hoping one of the slides coming forward will be helpful, but it's not like an instant on and off switch, right? And so behavior change takes time, and there are many things that help people change behaviors. And so overall, yes, maybe there are some small things that are reinforcing in the moment, like a trinket, as you say, or a small monetary value, but it's a small thing that is rewarding and makes a person get a little joy for just a moment. And that's not a bad thing. And if it helps them later make a different choice, then that's good. And absolutely, family is a top motivator for a lot of people entering treatment, but those relationships can take time and a ton of work. And so I think we frequently work with people on short and long-term goals. And so think about these kinds of contingency management and behavior changes as short and long-term. It may be too much to fathom to repair a relationship that's been really hurt over a long time in just a short period of time. But that's something to work for long-term, and then you break it up into small pieces. And that supporting a person and allowing them to, and then them learning that they can have successes in smaller ways initially brings a lot to somebody's sense of self and agency, and gives them some more coping skills to be able to tackle those harder things, right? And eventually get to where they want to be in terms of repairing family relationships. But like Dr. Loftwell said, those family relationships, sometimes it can be really painful to work through some of that. And you need to build up some of your coping skills first to tolerate some of the distress that will then come with doing that work with your family. So it's a process. And it doesn't mean that if someone initially in treatment is earning a few dollars here and there, or they get a gift card, or they get a pair of headphones, that doesn't mean that they can't, if they don't have those later in treatment, that suddenly they won't do well. Because at the same time, you're working on all those other pieces. I don't know, Michelle, if you want to add anything.
I think, I need to step into and confess when you said headphones, because I stopped and bought me some at Walmart this morning. So maybe it's my personality or my social position. I need to think on a different level sometimes as a coach. And, so I think I'm going to back off of, I get it. And I just I appreciate everything that you guys try to teach us.
So Tim, I agree with you completely. It is ideal if we can get people to do behaviors that are healthy for them and not do behaviors that are not healthy for them based on culturally appropriate, intrinsically rewarding things, like you say, like family and just like love for other human beings and a sense of purpose and all those things. As a psychiatrist and hearing specifically, we have many people from criminal justice here on this call. I'm just going to say, like, part of like the psychiatric evaluation and even primary care evaluation when they're treating patients with substance use disorder, I try and do a very careful assessment of early childhood behaviors and personality kind of vulnerabilities. And there are things that are really interesting that are very variable. So while, you know, most of the population has a personality that is within 1 or 2 standard deviations of kind of what we would think of as normal, right? There are people on the extremes, and sometimes those people on the extremes are very slow to be conditioned. Like, it's very hard for them to change behavior based on reinforcement, okay? And then there's some, you know, and I think it's definitely not the most, there's a minority, but as a psychiatrist, they exist, that are, they're not intrinsically motivated by things that are culturally appropriate. And I think, again, that is really, really the minority, but those are like why when you do an initial assessment, it's important to ask, you know, when you were growing up, were you ever cruel to animals? Were you ever cruel to other living things? You know, like there can be very, we need to be aware of all different types of people and how people learn and what reinforces them. And so while most people are going to be in the normal range, there are people that are not, that we need to really have different treatment plans. And I think this is why it's important that you have a comprehensive assessment and we not try to think that it is one size fits all, right? I'm going to have a different treatment plan for someone that really, before they had a substance use disorder, if there was a lot of sociopathy. Okay. And then you know, when all the kind of problems with legal were all in the context of the substance use disorder and for the purpose of getting substances, which is the majority of folks, that's different too. And then if I add on someone who has a lot of psychiatric comorbidity, like bipolar disorder or something else, I'm going to need to take that into consideration too. So, I think what you're saying is, I'm so happy you did say it, because I think this is it's an important discussion. And what you're saying is the goal is to get people to be intrinsically motivated by having meaningful relationships with others and feeling a sense of purpose and getting to those feel good emotions from pro-social behavior. But that can take a long time. And just in kind of the normal person who suffered from addictions, had some legal consequences, a lot of those relationships don't exist, and they're more traumatic and punishing, and they need to develop new ones. And sometimes to get them to develop new ones, we need to give kind of little tokens or other things to kind of say, it's okay to try this, right? And to reinforce that with vouchers if we can get them. And if we can't get them, which it's really hard to get them in standard clinical care, then we try to do that with our, what you do, Tim, you smile, right? Every time I hear you talk, you smile, you've got a jovial voice, you always are saying something positive, even if you're gonna kind of say something that sounds like it's a criticism, you're always saying something at first that's positive, and you're making it really clear that you're not there to attack, that you're there to help and to understand. And so we try and do the same thing in treatment, you know, so like, even if someone is going to is using and comes to treatment, we're always happy to see them regardless of what their urine test is going to show. We're always saying, you know, we're glad you're here, we're glad you came. And then, we'll ask people what they're going to test positive for before they give their urine specimen. And when it matches, when they tell us the truth, regardless of if they use or not, we thank them for their honesty. We thank them for their honesty. We teach the staff that, we teach the providers that, because we can't help them if they're not honest, right? Instead of saying, oh, damn you tested positive for meth again. Okay. It's like, thanks for telling us the truth. What happened? Let's kind of, the physician word would be that we're going to do a kind of dive in and do like a functional behavioral analysis of that positive test to kind of figure out what the cues were, what the situation was, and how we can alter that in some way. But I think these are the exact conversations that we have to have. All of this, like the behavior is in the seat of the brain. It is the most complex organ that we have. And if I had to actually think consciously about every single word that I'm saying and have said and so far, like, that would be impossible, right? So, but I've learned this over time. So we have to think about what our patients have learned, what your clients have learned that presenting to you, try to understand that. And it's really hard to get that to change.
Wow. Thank you.
So, Michelle, Victoria asked kind of like the whiteboard activity to map out what led to this slip.
Yeah, exactly. I think, like people, places, things, emotions, stress, all of it is kind of grist for the mill, and none of it is said in a punishing way. All of it is said like in a, like, let's really understand this. And lots of times the person doesn't even understand it. Like they'll feel a lot of shame. So it's just really trying to get the person to talk with you about it. You're really interested in it. You see this as part of like a solution. And, even if you don't get the answer right away, just the whole idea that there is safety in talking about what's happening in their life can lead to future openings for changes in the way we do things. But yeah, I have, if you have a whiteboard, that's great. I actually have those big Crayola kid sheets. I call it my big paper. People make fun of me. You know what I'm talking about, where it's just big paper, huge. You get them at Target, whatever. It might have like Shrek on the cover or whatever Disney movie is playing. I bring that out and I have Crayola pens, and I have colored pens, and I have pencils. And, I invite the patient along with myself to start making kind of the roadmap, and we draw arrows and cross things out, get messy.
I think that would be the piece of data to look at, that just like when you took the time to explain that to me, and that took, whatever, 5 or 10 minutes, versus when it comes to counseling, the times that the client sits in front of a qualified counselor, their chances of success to stay in recovery, I'd say just start jacking up, just start getting higher and higher and higher. But that time, if it's not, if it's just a courtesy, run of the mill counseling session, then the bar didn't move. But I think someone like you could move the bar on somebody where, what I'm saying? It's just, I think that's what the data would show.
So I think this was a really good discussion. So this is related to some of what we were just talking about. And it's more, one of the approaches we talked about last week was community reinforcement, which is the same concept, but essentially working towards pleasurable and healthy lifestyle that's more rewarding than one that includes drugs. So it's finding those alternative reinforcers in life that are intrinsically motivating for the individual person and that do not involve drugs. And so ultimately it's working towards improved satisfaction with, various aspects of life, setting goals, getting specific skills training, maybe in communication or jobs skills training, managing cues and triggers to change the behaviors around cues or triggers for drug use, and helping people move, along that continuum of behavior change.
And this is where criminal justice, I think, sometimes can be really helpful for someone that's struggling with this. So like if you have someone who's on probation or parole or is part of a drug court, and if there can be really good connection between the treatment provider and the probation, parole, or drug court, where there is, at the onset, an agreed upon what's going to be shared back and forth. If the person does violate their probation or parole or conditions related to the drug court, but if they have a job, let's say they do have a tax-paying job, then it would be great to not mess with the job, right? Because the job is something that we want the person to be a tax-paying citizen, but we also want them to have to fulfill their contract that they have with drug court and pay their amends reparations that they have to do. But if that could be done like on the days off, right? So if they violated probation and they have to do a couple of days, or if they do a couple of weeks, if those could be set for the days off of work, so that we don't set the person back in terms of the positive gains that we do want to see from someone who's criminally justice involved, or really anybody. We want everyone to really have tax-paying jobs and be contributing. That's where you can have really powerful change, because it's saying, look, we really like what you're doing here with the job and doing this, but you messed up here. And so you're not going to have the freedoms here. You're going to have to continue to do this to earn your freedom. So that is, I think, something that we're always trying to do, is that when there is sort of a punishment that has to be delivered because of the way the legal system's set up, to try to not have it undo the new reinforcing healthy behaviors that are good, because it's really hard for someone to be perfect all at once. They're frequently going to be doing some good things that are good, and then they're going to mess up with other things. So to the extent that we can take our systems and not hurt the positive changes, and try and use things to really have it be really focused. So the message is really clear that this is doing good and we're not going to harm this. Do more of this. Don't do this. And there's a JD PhD that works in Pennsylvania with a lot of the criminal justice, and I'm forgetting his name. I think his first name's Doug, that's done a lot of work here in this area. And I can't remember his last name, but Oslo, Doug, oh, I
don't know. Michelle, do you want to comment on this anymore? Otherwise, I think I'll move on to some of the other questions.
The network therapy?
Yeah, it was just one of the other modalities that we talked about last week. This is more of a behavioral therapy.
I love network therapy. It's like the common sense use of supports, really. So this was something that Mark Galanter, he's a psychiatrist at in New York, kind of really started, but it's really just saying that everybody who has the person's best interest at heart becomes part of the person's treatment team, like where they actually know the person's appointments. They can even come into the part of the appointment. They know where the person goes. The patient may sign consent to release information to them. So that way they'll know when the next appointments are, that really are just there to support the patient's attempts to go into remission and have the recovery that the individual wants. So they showed that people do better with a larger network of supports compared to those that had no network supports.
So there were some questions that came through in between. One was about the success rate of persons attending 12-step programs as part of treatment. And hang on a second. Yeah, okay. So this question is a whole nother talk. So thank you for bringing that question. But I want to make the distinction between 12-step facilitation and community-based 12-step programming. So 12-step facilitation is a manual-based studied behavioral intervention with a trained clinical provider, social worker, professional counselor. That is just, and there are studies in that, particularly I think for alcohol use disorder. That is, but what most people are thinking of when they say 12-step programs are AA, NA, community-based programs that are facilitated by volunteers, so not clinical professionals. And so that is distinct. And there, I just want to share that there is going to be a Kentucky Open session focused on 12-step programs specifically. So integrating participation in 12-step programs and medication for opioid use disorder in August and September. And for those of you that maybe want to learn more before then, we wanted to point you to the PCSS Provider Clinical Support System Substance Use Disorder 101 core curriculum, which has a module on 12-step programs. But it's not, there isn't one answer to this question. Largely, the 12-step programs in the community are so diverse and heterogeneous. So there isn't like they aren't studied in the way that, you know, some of these other behavioral interventions have been done in specific clinical treatment environments. So in clinical practice, and I'd encourage any of you to jump in here, but I encourage patients to participate in community recovery support activities. If there are 12-step programs that they find helpful in their community, that's great. But one of the things that sometimes we help patients navigate in receiving medication for opioid use disorder is sometimes 12-step community programs are not supportive of receiving medication. And so that is something that needs to be navigated. And I do see a lot of internalized stigma that people come into treatment feeling that receiving medication is somehow wrong. And so there are more and more meetings now that are accepting and encouraging of medications and also all paths to recovery. And so we try to encourage our patients to participate in those. Michelle, I don't know if you want to add anything here or people have specific questions.
No, I think there's MARA, Medication Assisted Recovery Anonymous. That's like specifically 12-step. That's for people on MOUD. That hasn't expanded so quickly as we would like. So I think like locally we'll hear from patients like this is a good AA meeting that it, it's a good AA meeting that is, it's okay if you go there and your problem is not alcohol, it's other, that it's opioids and they're accepting of people being on medicine. And then there's others that are like, yeah, don't go here, so there's some word of mouth that I think it has to be done. But in general, I think that the idea is that we try to always encourage people to try it and give the advice that they just kind of go and listen first. Like they don't need to be the most active participant the first time they go, and just see how it feels in that. Because we know that for a lot of people, it becomes a really important part of their remission and recovery. And for others, just the idea that they go to any group is like, gives them a panic attack. So, we know, I think there's a lot of research and nice writing about, what's the mechanism through which 12-step has helped people. And, there's some common themes, like just the idea of, a close network, social, that people need other people, an idea of, an acceptance, no matter where you're at, taking people back, even after they have slips. And so just in having a curriculum for some people is also very, very helpful. And this idea that you're working with someone else and that you have, a sponsor is also critical. Someone I think that's just kind of going, but isn't actually working the curriculum, isn't necessarily getting the same benefits as someone who is going through the curriculum. And I think that could be said of other kind of behavioral and counseling interventions. If someone's just going to group and just sitting there, that doesn't mean that they're benefiting. There have to be kind of actively participating, and same for individual treatments as well. You could give people homework to do for their CBT, but unless they do it, it's not going to really be internalized.
So Tim asked a question about, just not sharing that information that you're on medicine. Yeah. So like any medical issue, any medicine that you're on for any problem that you might have is private, and it's up to you whether you share it or not. So I think that is one thing, one approach. The problem is that even if you choose to go to meetings and you don't share information that you're on medication, you might hear negative things about what's working for you. And that can be internally inconsistent and feel bad. And so generally, I encourage patients to participate in recovery support activities that are helpful, that make them feel better about themselves and build positive relationships with people that are going to lift them up for the positive choices that they've made, and not feel bad for choices that they've made that have actually been really good for them. So I think that's my perspective on that. But again, that's personal. That's my personal style when talking to patients. There's no science behind that approach.
Well, I think that's really valid, because one of the problems that we see, and something that will always break our heart, is the patients who are in full remission and have been doing really well, and then because of some outside influence decide that they shouldn't be on medicine anymore, that they shouldn't need to be on the medicine, and then they stop coming to their appointments, they go cold turkey, or they just self-taper, and then they go back and use, and it's the end for them, that they die. So this is a really important topic to talk about. What's, if they do go and they do the don't ask, don't tell, they should be talking about it with their provider, with a counselor, with someone, to see how it really is affecting them, and how they are internalizing those messages that they might be hearing. Like we would say the same thing with someone with that finally gets their diabetes under control after having hemoglobin A1Cs. They're just so high, and finally is not in and out of the hospital, has a good regimen going. And then, someone telling them, oh, you're doing well, why are you on medicine anymore? You don't need that. you know, it's proof you're doing so great. Your sugars are under such good control. It's time to come off the medicine. Like, that's insane, you know, but that doesn't minimize all the work that the person's done to manage their illness. So I think it's really important. I think that I go farther than Laura and say it's really important that they find a network of people that accept them, where they don't have to hide pieces or parts of them that are pieces and parts of them that actually keep them alive and on the earth. So this is why I'm grateful for like new groups that we know by definition are accepting of all pathways and all medications. And those are smart recovery groups and MARA groups. So
Yeah, and when you're out there boots on the ground in a meeting and they start talking about medicine, I just pivot away from it and say, you know, smart recovery doesn't really take a stance and, you know, kind of, because wow, you'll have 4 people in the room and 4 of them have different programs, different treatments, different thoughts. So, you know, I go back to the tools and say, let's focus on this instead. So it really surprised me how many views and how they want to wave the banner. Somebody wants to wave the banner of this or that, or my treatment or my medications. And, you know, I'd rather try to find common ground to build that group community through smart recovery.
yeah, there's a lot of diversity. So I think that the more diverse we can be and more accepting, the better it will be.
One thing that I'm finding now is a lot of the guys that are in NA in particular have been around NA for anywhere from 12 to 15 to 20 to 30 years. They've seen so many people here in the last 5 or 6 years that have come in, tried to do it the NA way, and they didn't make it. So many of them have died. So many of them have gotten back into medically assisted treatment. And they're way more acceptance of it because, you know, there's a few of us that are just pulling some of these guys aside that we've known 15 years and saying, here's the science on it. So little bit by little bit by little bit, you know, once these, the guys that have been around like 30 years, 35 years, once they know the science, they've really softened their stance. And so now they're having a little bit of conflict from the foundation of NA, you know, way back. And they're coming to the point that we've just got to love people and try to work it out the best way possible for them. Not try to force somebody to do it our way, when obviously they've almost died a couple of times trying to do it our way. So that's loosened up a lot, you know, and I continue to do that. I mean, sometimes I get home and I'll stop by somebody's work or something that's been around for a while and spend 15 or 20 minutes with them, you know, and I usually do something like bring them donuts. That stops them from working, you know, long enough to talk to them. But little bit by little bit, it's starting to work. Maybe that's local. That's definitely, well, I don't know if it's international or not, but locally, there's much more of an acceptance of what it used to be. And believe me, I was one of those NA Nazis, you know, for the first 12, 13 years of my recovery. It's just been in the last year and a half where I've learned so much more and I've seen so much more and experienced some problems with people that I thought ought to do it my way that died. And so, you know, I'm definitely an advocate, because here's people trying to help people and they don't know who they're hurting. Sometimes being able to get them aside one-on-one and show them some of the science, you know, that's, I think that's going to help us, all of us. But I mean, it's a tough go. You can't go to 100 people at once. Like Tim said, I mean, you know, they're all going to have different opinions. But go to the ones that have been around a long time and show them the science and get their opinion on them, and then come back later and ask them. And some of them are starting to experiment with that. So hopefully that's going to go on. I mean, I'm a strong advocate for it now. And I know how I used to be. So I know what some of these guys are thinking. But this helps. The more and more I see this, the more and more ammunition I have to take back one-on-one to the sponsors that have been around a while. Some of these sponsors have like 200 and 300 people in their line. Like my sponsor's probably got 1,000 in his line all over this side of the country because he's been 35 years clean. And he's starting to change little bit by little bit. So there's hope. There's definitely hope.
Well, that is just the best thing I've heard all day. Thank you for sharing that. It's really, really incredible to hear that story, and also just very hopeful that, and this is the hard work, but I think it's so critical to, as you said, to share your own process of changing your and help others do that as well.
Yeah, I ditto that. And I love that you paired it with donuts. That, I don't know if you said that on purpose here, but you gave an immediate positive reinforcer, sugar.
I thought the same
Like a
thing.
message that you are delivering. And we do that all the time, right? You want
Yep.
someone to kind of really make sure they're listening to you and that they see you as a friend and not a foe. And you do that by not only your demeanor, but what you bring. So you brought, yeah, you got it.
That was perfect illustration of what you said earlier. That's for sure.
You know, the thing about it is they're soft enough where they're not crunching anything so they can hear you, but they got a mouthful so they're not talking.
That's right. You don't want to be bringing nachos or tortilla chips or potato
Exactly.
chips. Right? Yes, yes. You're the pro.
But donuts are positively reinforcing, I will say. So I think we talked about this question already. And just a reminder that, you know, this process of behavior change takes time. And so when we contextualize substance use disorders, the way other chronic medical illnesses are, is that relapse is part of it, and that there may be periods of time where someone isn't doing as well, and then periods of time where their illness is in remission. And so we shouldn't have different expectations for people dealing with substance use disorder. I think there's such a common perception that if someone enters treatment and doesn't stay in treatment long term and maybe returns to use, that they never will get better, but that couldn't be further from the truth. And so this is a helpful, I think, schematic to think about what can, you know, the process that people go through is that it really can take years sometimes. And this is not true for everybody, but this is the critical piece, is that people, every time someone re-enters treatment, this is something to celebrate and something to welcome them back. And so we always, you know, there's always a lot of shame when people start in treatment and then they maybe fall out of treatment and have returned to use, and maybe they come back into treatment, and as Michelle said earlier, that's, you know, that's, you frame it as a positive. I'm so glad you're here. I'm so glad that you made the choice to come back in. Let's see where we can go from here. And so it's part of the process that people may need multiple treatment attempts to achieve sustained remission and long-term recovery, but the majority of people do. And so I don't know if anyone has questions or comments on this idea, but
I think it's consistent, like this is consistent with really thinking about it as a chronic relapsing illness. And then I think like just the whole behavioral change thing and the idea. So someone had, I think there was a question earlier about, is it sustainable? Is giving, I think they were basically asking, are rewards sustainable? Like if you keep paying someone to have a negative urine, when you stop paying them, will they continue to have a negative urine? And the answer is, in research studies where you're literally paying someone like with money or a voucher, when you stop paying them, there is no guarantee that they're going to continue giving negative urines once that reinforcement has stopped. But that's why we are doing the healing study, right? Is because the healing community study is really trying to get healthy communities. This is why we have the Voices of Hope and the Bluegrass Care Navigators, really trying to find everything in the community that can be used for community reinforcement, right? Like to make sure people have things that are reinforcing, that they have things like home and housing and adequate food, and why we want to help people get jobs. You know, like we need healthy communities that make that intrinsically rewarding, you know, feel good endogenous opioids available. And we need to keep them alive until we can get that whole system going. So the medicines help them stay alive, and then you try and help them get that whole other way of life around them too. And you try not to punish them for the good things that they are doing, making change. So, you know, we know there's a lot of hurdles to jump here, because we know we've got lots of people with felonies, and then it's hard for them to get a job. So we've got to find ways to help those folks when they do get a job, keep those jobs, and have housing that allows them to be on medicine and isn't, you know, getting them in trouble and saying you can't be here because you're on methadone or because you're on Suboxone. You know, like we need to make sure that we're not going backwards.
So examples of a reward system for people with limited resources. I mean, I think there are definitely, we've talked about this a lot, but there are reinforcing, rewarding things that are not monetary. Michelle mentioned earlier, outside of clinical trials, it's hard to pay patients actual money because clinics don't typically have extra cash to give people in that way. So the way community contingency management is set up in real life frequently is with those reinforcers that are not actual cash typically. So sometimes we have money that we can pay for transportation, so maybe bus passes. Sometimes we can give people a meal voucher. Sometimes we can give rewards. I guess the word before was trinkets, but maybe some things that are fun, candy, donuts. And then also the things like more take-home doses. So that's a reward. Not having to come in as frequently sometimes is a reward for people. So those are some examples. Are there resources or strategies available for patients or families interested in behavioral interventions in rural areas or with limited access to care? Actually, here I was thinking of actually talking about the virtual retention approaches that we talked about in the beginning of this QA session, Reset-O or other virtual approaches. But I think, you know, this is a consistent problem in treatment access generally.
I think some of like the novel things that we're trying to do and heal, like where if we hear about an overdose, where we have someone reach out to them, you know, I think some of the peer supports and quick response teams. Those are behavioral interventions. You're hearing about a behavior, you're reaching out to the person to try and hook them up to resources. Some of those interventions really are not that costly to do. And so, you know, I think that if you have someone, you know, someone that wants to give back, you know, volunteering with any of these organizations, with, you know, volunteering to, you don't have to be a specialist or have certain credentials to learn how to lead a smart recovery program, or, you know, to volunteer in a food bank or somewhere else. Those are all places, I think, where you can show support for your community and to people who might be struggling with substance use disorder, and to give that encouragement, to know that, for those people to know that they're part of your community, that you want them and you want to see them get and stay healthy. Lots of times communities have resources, but the people just aren't aware of them. So I know that's been my experience, seeing all these community resource guides that were made up for these different counties. So
yeah, so I wanted to use that question as an opportunity to highlight the community resource guides, which were developed for each county participating in the Healing Communities study. And these, you know, again, highlight some of the local resources that are available in these areas. So we're getting late on our time. Let me see, where are we in our session? Oh, there's still more. Okay. Let's see.
does anyone want to pipe up with a burning question, since we've been having such a rich discussion? Nothing's burning. Is anything like slightly simmering? I can keep going, and I have very corny kind of saying, so I will.
Need to throw something out there.
Yeah.
I know quite a few people that are in conventional, I'm talking about outside of, you know, the clinics and so forth, that are doing medically assisted treatment. I know quite a few other people that have come through treatment centers, that come through organizations that still are going, no, you're replacing one drug with another. Is there any type, and this is a suggestion maybe, is to maybe put out a, you know, some type of notice where you don't actually single one person out? Because I know if I go in some of these places, they immediately say, watch out, he's going to be talking to our people, you know. Not really, but I mean, they know who I am sometimes. And I'm thinking, maybe is there a way to maybe put up maybe a communications board, or maybe even have, you know, something like maybe outdoors at the Bridge Clinic and so forth, where some of the peer support people, especially like the people that are in this group today, talking to the other peer support people that don't have the knowledge, don't have the information that we have. You know, and so a lot of these people are depending on doing, you know, they're depending on their peer support job for an income, you know, sometimes to feed families and so forth. And they're scared to start talking about this when their employer says, no. And I don't, just want to throw that out, because there are employers doing that. You know, in my employer, and I love my job and I love what you're doing and so forth. But, you know, there's things that they do that it doesn't fit with what I've learned. I think it's changing. It's definitely changing, because they're open for that. But gosh, it's slow. I mean, I've been there a year and it hadn't moved very much at all. But I don't know if there's some way to, you know, start to connect with on the peer support level. Because I know sometimes you can change everything when you're starting from the bottom versus, you know, versus pushing down from the top. Just wondering on that, if anybody's got any ideas on that.
I think that, you know, some of us aren't old salts like you, Tom. And so we're trying to learn our way, that maybe as they continue to teach us and we come to Kentucky Open, we'll have that skill set that we can go toe to toe with people who have different views. So I think we're in process right now.
Yeah, I definitely don't think it's doesn't need to be a struggle. You know, one thing I've learned a long time ago, and this is, you know, from teaching, teaching sales and so forth, is the questions are the answer. So you start asking questions and you say, aha, oh, now I understand what you're talking about. Then have you considered this? You can take that forward. Use that in motivational interviewing and so forth too. I really want to know where they're thinking, what they want to do, what they think is going to be right for them, because a self-directed life, everybody's entitled to that. But some people don't know how to ask those questions. But anyway, as I say, some type of an open type thing, and to where this goes out, maybe something like a newsletter or something coming out of Kentucky Open or something might go out to peer support people everywhere, and then let the rest of it just take its natural course.
Well, any peer support that's working in a Wave 1 community right now would be totally welcome to join KY Open. So we are happy to have them.
Yes, if you know anyone that's in a Wave 1 community that might be interested in attending KY Open or just learning about it more, feel free to direct them my way, and I'm happy to give them information about the newsletter or talk to them more about KY Open. But at this time, KY Open is just for the 8 Wave 1 communities.
For a lot of us, we work in some of the Wave 1 areas and some that are not, So I've been trying to pull them in here, even though they might be based in a different place. They're on the streets here in Lexington, and they're doing a lot of volunteer work here in Lexington. They're doing, they're reaching out, and they sponsor people here in Lexington, and they may work 60 miles down the road like I do. Just trying to pull them in as much as we can.
Yeah,
I think that's
totally okay.
Yeah, that's the spirit of it, right? So they're interacting with people in one of our counties, so they can be included. But I think what you said, is really important, that changing culture takes time, and that your voices, as you said, from the ground up are really, really powerful and important. And so thank you for doing that work. I know it's hard sometimes to have these difficult conversations with people that maybe don't agree. And so I want to express that is recognized and really, really important. The other thing too that we're trying to work on is, as we've talked about, part of the problem is that the payment structure for treatment still pays for treatment that maybe is not always evidence-based. And so that's something also that will take time. And if there's no reimbursement for services that don't include medication for opioid use disorder, then slowly that treatment framework will decrease too. And so I think we have to continue to work together in a multi-pronged approach to improve treatment that people receive in our state.
Do you sometimes have to go to bat for MOUD with your peers?
Are you talking to me or to her?
No, I'm talking to Dr. Fanucchi.
With physicians?
Yeah.
And all the time.
Okay. I wondered if you had to have that hard conversation with them as well, and how you would, be the advocate for our position for MOUD.
We have these conversations all the time with our healthcare system, with colleagues. And it just takes time to build a community and to change what has unfortunately become, I mean, the treatment structure that we have now took a long time to get where it is, right? And so, so yes, we're in there, we're in it with you.
Laura's fierce, Tim. She's like, she comes off all quiet and demure. Yeah, not so much when you see Laura in action. She's always professional. But yes, I mean, Laura has made the case to have an addiction medicine service. And she kind of single-handedly had to find other like-minded doctors in order to do that. And so I think she was really successful in that, but it's only gotten better as she has been there with her team, showing people that it works, just like you're saying that it's over time and it's, you know, it's like one by one by one. I really, really, really do believe that this is the only way things are going to change, is by the people, is by the communities, by the individuals. And when you look back at like policies and politics, politicians don't frequently lead. They follow what their communities want, what their constituents want. And if the constituents are making a switch and saying, hey,
Where the votes are.
we want this, then their music is going to change. So I think it really is up to us and our communities to be the ones to say what we want. And I think to know what we want, we have to be educated so that we make the best decisions for ourselves and for our loved ones, and that we let other, you know, and we let those people choose based on the facts, on science.
I think you just communicated the big picture right there. I think I saw it.
I got a question. What's the possibility of putting together like a mini 50-50 waiver thing that, you know, that people such as myself, maybe in conjunction with one of the doctors, that could, you know, just go over the, you know, the slides and things like that. I mean, I feel I could do that, but I wouldn't want to do that because there's so much I don't know. I mean, I've taught for years, you know, and had to learn things on the fly, but I'm just thinking that at 50-50 waiver training with you and with Dr. Oler, I mean, that turned my world upside down. And I couldn't stop digging into that. And I had to look up all those Latin names. And fortunately, I had a good mentor that just sit with me and explain the brain to me, you know. Of course, he was also sitting in a hospital bed with two knees replaced. He couldn't go very far. And some of you that's been around UK long enough will know James W. Holsinger. So he's retired, but at 82 years old, still the smartest man I believe I've ever met. So and he would be one that would love to speak on this, you know, with something brief, you know. And he's a powerful speaker. But I mean, if that's something like that, you know, some type of a small presentation that would kind of get people interested, and then pull them into, you know, pull them into some of the trainings. Something like a teaser, you know, PowerPoint or something. Is that possible, or at least throw that out to be thought about anyway?
John, you're our educational coordinator.
Yes. So we have, so one thing that we do have is we had an introduction to MOUD with Dr. Hawthorne that I think is actually a really excellent, having attended a handful of waiver trainings myself, just as the education coordinator, I would say that introduction to MOUD talk by Dr. Hawthorne is a really excellent introduction. So if they're part of the Wave 1 community, you could make that resource available to them. And I think that would be an excellent way to get that information across. Hopefully that answers your question. Okay, great. I want to thank Dr. Fanucchi and Dr. Loftlaw and everyone for this really great conversation that we had today. This is really lively Q&A, so I just want to thank everyone for their input today.